Okay, I'll start again. Thanks for letting me know. I'm Kate Young. I'm going to be presenting the first lecture of the Introduction to Biostatistics for clinical and translational researchers. I'm a research assistant professor in the Department of Data Science, and here's my contact information if you have any questions about the course or anything. Just to let everyone know, the lectures will be recorded and links will be sent to all registered participants by email, probably later today. So the objectives of this course are, one is to understand the role of statistics in the scientific process and how its core component, how it is a core component of rigorous science and evidence-based practice, to understand the features, strengths, and limitations of descriptive, observational, and experimental studies, to distinguish between association and causation, and to understand the role of chance, bias, and confounding in the evaluation of research. So I just wanted to give some training and educational resources before we get started. And these slides are on the meeting invite for this course. So if you would like to go into any of these links, you can use that. So we have graduate courses in the Department of Biostatistics and Data Science and biostatistics, epidemiology, data science, data management. There's also grant writing, scientific rigor and reproducibility, and systemic review and meta-analysis courses. We also have graduate certificates in biostatistics, biostatistical applications, and health data science. And then we have some degree programs in health data science, clinical research. And then Frontiers is also a great resource for biostatistics and clinical and translational research. And then the KU Cancer Institute also has a K-12 scholars program. So there's the link to that. I also wanted to give you some online resources, the Center for Open Science, and then a 4-part series on statistics and clinical trials. And then RStudio is what we use a lot in the department for data visualization, data analysis, data mining, that kind of stuff. So it's a free and open source tool. So if you want to learn more about that, the link's right here. And then there's a few more online resources. To give an overview of what this course is going to look like, part 1 is going to focus. I'm going to give a brief introduction to scientific rigor, and then we're going to go into experimental design. And then part 2 is we're going to look at statistical methods for visualizing and analyzing data. We're going to do a review of hypothesis testing, and then we're going to look at the student's t-test, analysis of variance, and chi-squared analysis, which is used a lot in clinical research. And then we're going to do a brief discussion of sample size considerations. And then part 3, we're going to go more into statistical methods, and we're going to look at correlation, linear regression, analysis of covariance, logistic regression, and survival analysis. So starting with part 1, if you were able to watch the video before coming to this class, this might be a little bit redundant, but I'm just going to give a review for those of you who weren't able to look at those slides. We're going to talk today about scientific rigor and reproducibility. We're going to look at the differences between repeatability and reproducibility, and how those are assessed. And then what types of errors can affect reproducibility of a study. what are the ways that we can minimize the chance of producing an inaccurate result of our studies? And what are the 3 common questionable research practices that can prevent a study from being replicated? Rigorous science involves theoretical or experimental approaches in a way that enhances the confidence of our research findings. And probability and statistics are a key component of scientific rigor. So some key principles of scientific rigor, even in very well-conducted studies, there's always a risk of a false negative or a false positive finding. And this is due to sampling variation. Sampling variation is caused by us working with samples from a population rather than the whole population. So when we conduct research, we often have a population that we're focused on, but we'll only take a small subset of that population when we're trying to design our study and come up with a cause and effect relationship. So several randomized controlled trials are always better than one because different randomized controlled trials will get different samples from the population, and this will give us more confidence in our results. All studies can be repeatable. So this repeatable means is that using the same data and the same methods, we can obtain the same results. However, not all studies can be replicated. And replicated means that if we use the same methods on different data or a different sample from the population, we would obtain different results, but similar. So to go more into detail on that, this figure demonstrates repeatability. So that is, if we apply the same methods to the same data 20 times, we would get 20 identical results. So this is the same methods, same data, and we should get identical results. However, reproducibility is when we use the same methods on different data, we'll get different results, but we would expect those results to be similar. Just a note about confidence intervals. So this is where the term or the concept of a confidence interval comes from. So if we calculate the 95% confidence interval for replicated studies from different samples of the same population, 95% of those confidence intervals will contain the true value of whatever parameter or measurement we're trying to evaluate. So non-replicability can arise from a number of sources. In some cases, non-replicability arises from inherent characteristics of the systems under study. In others, decisions made by a researcher or researchers in study execution that reasonably differ from the original study, such as judgment calls on data cleaning or selection of parameter values within a model, may also result in non-replication. So other sources of non-replicability arise from conscious or unconscious bias in reporting, mistakes or errors in either analysis or the conduct of the study, problems in study design, execution, or interpretation in either the original study or in the replicated study. In many instances, non-replication between two results could be due to a combination of multiple sources, but it's not generally possible to identify the source without careful examination of the two studies. One thing we're going to look at today is whether a study is internally valid and whether it's externally valid. So internally valid means that the study results are unbiased and precise. And then externally valid means populations and settings. So I wanted to briefly talk about the p-value because this is used a lot in clinical research, but there's usually people have a misunderstanding of what the p-value represents and what it means in the context of the study. So what the p-value does is it helps by linking an experiment's outcome to the types of random samples that the population might produce. So this is related to the sampling distribution, which is the probability of observing different study results. So like I said before, multiple studies can be conducted in one population using different samples of data. So those different samples of data will give us sampling distribution of the actual parameter value that we're trying to estimate. But one thing to note about the p-value is when there are all other sources of variability other than the sampling variation, the p-value cannot be interpreted. So when a study is not internally valid, we cannot properly interpret the p-value. So let's look at an example where we have 3 investigators who are each independently interested in demonstrating the progressive deterioration in heart function observed in patients with mild congestive heart failure. So all of them are going to be focused on left ventricle ejection fraction, or LVEF, but they also collected other measurements such as end diastolic volume, end systolic volume, and stroke volume. Investigator 1 in their study, they find that there has not been an important change in LVEF. However, they did find that EDV has changed substantially, so he changes the endpoint of his study and then reports that. Investigator 2 found no change in either LVEF or EDV, but did in ESV. And then investigator 3 noticed that SV, LVEF, EDV, and ESV did not show any promise of change. So as a result, nobody reports the LVEF, which is what was the prospectively defined endpoint. So what they defined as the endpoint before conducting their studies. So unfortunately, the decision to change this endpoint was data-driven. And so this adds more variability into their studies. So by deviating from their plan, they're introducing more sources of variation. So now the p-value will account for both, or will contain 2 sources of variability, both the sampling variability from the 3 researchers taking 3 different samples, and then also from the variability of changing the endpoint selection because they changed the endpoint. So this this variability introduced by something other than sampling is what destroys the interpretation of the p-value. So switching outcomes can result in overly optimistic results in favor of a new therapy, especially when the switch is made to increase the chances of publication. So switching outcomes violates these assumptions of the p-value, and therefore it cannot be interpreted in this instance. Some more comments about the p-value. 1, the p-value must be the result of a well-defined, prospectively fixed experiment, where the only random component is the data itself. There is no theoretical justification for p less than 0.05 for determining statistical significance. This is an arbitrary decision rule that arose from tradition. And p-values provide an estimate of the role of sampling error in research, but nothing more. So if there's other error in your research, the p-value will not be interpretable. One other thing to note is that the p-value does not measure the effect size. So p-values can also accompany statistically meaningless effects. And that's why the p-value should always be reported with the estimate of the effect size. So if you've been paying attention in recent years, there's been a lot of discussion about how scientific results have not been reproducible. So that is that one study may find some association while subsequent studies find no association, or other researchers fail to reproduce the results of the study. So why would this be? Well, there are things that we could be doing over the course of the scientific process that could mess this up. So this process includes generating and specifying testable hypotheses, designing the study, collecting data, analyzing the data to test these hypotheses, and then interpreting the findings, and then publishing or disseminating the results. So how can we mess up the steps in this process? So one, we can generate hypotheses that are not testable. There's also something called hypothesis myopia, where we fixate on things that we believe in our gut to be true and fail for whatever reason in considering that other hypotheses are just as likely as the one that we're really excited about. In designing the study, we could fail to control for sources of bias and sources of error. So sources of bias are aspects of the experimental design that could systematically push the result away from the truth. So this can result in a study finding a positive association when there is no association, or finding a negative association where there's actually a positive one, or any incorrect conclusion from the results. So sources of error increase the variation in the outcome. That is, you may lose a treatment signal in too much noise. And if we know about these things in advance, we can control them for them in our study design. We can also control for unknown sources of bias and error. Underpowering, this is a problem, and it occurs when there is too much noise in the data where we can't find a signal. So this could be oftentimes due to a sample size that's too small, or a failure to control for other sources of error. A study could also be overpowered. Now, why would this be a problem? If a study is too powerful, even small clinically meaningful associations can result in small p-values, making us think that there is a significant association, even when the effect size is trivial. There are also ethical concerns when a study is overpowered. So if we have too many subjects enrolled in a study that we don't actually need to find a significant result, these subjects are exposed to unnecessary risk from taking either an experimental drug or an experimental treatment. When a study does not use blinding when it should, blinding is not always possible, but we should blind a study when it is possible to avoid bias. And then another way we can mess this up is if we don't randomize a study when it should be randomized. So randomization can protect us from bias. When collecting data, poor QA or QC could cause inaccurate measurements or inaccurate data entry. Missing data will also introduce additional variability. Wrong methods, wrong statistical methods could produce wrong results. So, for example, statistical tests often rely on a set of assumptions, and if your data violates these assumptions, you could get invalid results. Another thing is p-hacking, which p-hacking is manipulating data in an analysis in order to produce a statistically significant p-value, and even when the effect is not real. So this can be done by selectively reporting outcomes, running multiple tests, or stopping data collection at a convenient point in the trial. And this inflates the risk of false positive and undermines the validity of the study. Outcome switching, also related to p-hacking. That's the example we showed earlier, where researchers changed their endpoints after looking at the data, excluding data for any reason other than if you know the data is incorrect. Just to find a statistically significant result is going to invalidate your findings. And then overstating findings. So we should always be aware of the limitations of our study when stating our findings, and then forgetting context. So forgetting what population we're drawing from, or how our inclusion exclusion criteria could impact how the real world application of a study in the real world could result in different findings. And then harking, which means hypothesizing after the results are known. So coming up with a hypothesis after you look at the data, and then reevaluating your results using that hypothesis. And then publication bias, which is the tendency for studies with positive or significant results to be published more often than studies with negative or null results. And this skews the scientific literature, making treatments or effects appear more effective than they actually are. And there are other ways that we can mess this up, but these are some of the more well-known ways. These are the ways that we can create findings of research that are not reproducible in other studies. And we can't point the finger at any one person or entity. This is an us problem. We are all contributing to this in one way or another. So journals are for-profit and can create pressure to produce or to publish attention-grabbing studies or positive results only, and failing to publish negative results. Newsworthiness is often prioritized over methods. Novel research is prioritized over replication studies. And like I said, positive findings are prioritized over negative or null findings. Researchers are employed by institutions where quantity sometimes trumps quality. Bigger is better, and many publications are better than one. And they use journal impact as a proxy for quality. Funders also contribute to this problem. They often don't like to fund replication studies or systemic reviews. And then as researchers, sometimes we can fool ourselves. We don't fully understand the statistics that we're presenting. We don't collaborate. So we have to understand that we're not experts at everything. And transparency is important so that others can help us identify flaws in our methodology. So the first step in improving this as researchers is to understand the things that we don't know. It's often the things that we don't know that derail us. So the cure is awareness. We need to seek out and improve our training in scientific thinking and research integrity. And we have to prioritize learning about questionable research practices. So we went over repeatability, reproducibility. We talked about how we can minimize the chances of producing an inaccurate result. And then we talked about common questionable research practices that can prevent a study from being replicated. So there's more detail. If you want to go into more detail about this, I'll look at the video that we sent out earlier this week, and it goes into more detail about these concepts. So next, we're going to move into experimental design. So again, we're going to talk about validity and what are the two protections for internal validity. And what is the most scientifically rigorous experimental design or type of research study? What does it mean? What factors go into a study design? We're going to talk about two factors, backwards versus forward directional, and prospective versus retrospective. And then when is it inappropriate to calculate risk? So experimental design is the process by which we can account for and minimize errors in our conclusions. There are many opportunities for errors in our experimental design. So any person, place, thing, or action that results in an error can be the source of inaccurate conclusions or the inability to generalize conclusions. So the goal for today is to think about how study design can impact or ensure the validity of our research. There are two ways to think about validity in terms of the goals of our research. One, to draw valid conclusions about the effects of an independent variable. So this is the exposure or the treatment or intervention. And then to make valid generalizations about the populations that we're drawing our sample from. So as I mentioned before, the ultimate goal of research is to determine a causal relationship between an independent variable, like an exposure or a treatment, and a dependent variable, which is sometimes development of a disease, death, or improvement in a patient's condition. So when we critically evaluate a study, we focus on determining the risk of that study's finding, that the study's findings are due to sources of error, like bias, confounding, or sampling error, rather than the actual effect that we're looking for. So if we determine that they play little to no role in the study, conduct and analysis of a study, then the study is considered internally valid. So in other words, the conclusions reached are likely to be correct for the circumstances of that particular study. So there's always some source of bias or some opportunity for bias in a study. And so we're going to talk about how our study design can minimize the potential for bias in our study. So this does not necessarily mean that the findings can be generalized for other circumstances. So if a study is internally valid, it doesn't necessarily mean that it's externally valid. In this case, externally valid means that we can generalize our research findings to the population that we're interested in. So for example, a study done in a VA hospital might result in valid estimates of a treatment effect, but those study results may not, we may not be able to extrapolate those results to other hospitals because their patient populations may be very different. The usual process of determining the validity of the study is to begin with a critical appraisal of the internal validity, and then from there, we can look at the external validity or the generalizability of our study. So this lack of external validity often results from having a study population that is not representative of the reference population. So as an example, we're going to consider a population of about 2,000 patients who are at risk of some disease who undergo an infusion therapy. So the true effect of this therapy is a 17% reduction in the risk of death or a relative risk of 0.83. Note that the relative risk of 1 indicates no treatment effect. So say that we conduct 10 randomized trials where each of these studies was conducted in the same way, but only in a random sample of 216 patients. The effect of the sampling variability in these estimates is very clear. So we can see that we get very different estimates of the relative risk in the 10 different samples. So this random error that we see is known as sampling variability or sampling error. And we can often combat this by sampling or creating a sample that is large enough to answer the question with a high certainty. So this is known as power. So the way we power a study is by allowing for a certain false positive and false negative rate, and then assuming some level of sampling variation, and then we can work backwards from there to figure out what sample size will give us enough power or enough of an ability to detect an effect. To evaluate validity, we can begin by considering the study's risk of bias. As a reminder, bias refers to systematic errors that can result in an incorrect estimate of the association between the independent and dependent variable. In many cases, the independent variable is the treatment or the exposure, and the dependent variable is the outcome, like improvement or development of a disease. And investigators can introduce bias into a study as a result of the procedures for identifying and enrolling patients. This is an issue even for a gold standard study design, which is a randomized controlled trial. They can also introduce bias from the procedures or from the way that they analyze the information. So one common source of bias in a randomized controlled trial is that missing data may result from how patients dropping out of a study may be a result of how well that treatment is working for them. So in this figure, I've plotted each patient with their subject ID on the x-axis, and then along the y-axis, we have some outcome variable or some indicator of whether the treatment effect was positive or negative for that patient based on some measure or clinical outcome. So any dots below this line indicate, any dots in red indicate a negative outcome, while the green dots above the line indicate a positive outcome. The problem here is that some patients may choose not to come back for a follow-up visit where we can assess the treatment effect. So you'll never see whether or not these patients have a positive or negative outcome. So let's pretend that we can see those individuals. So if we have 8 patients who did not come back and one experienced a positive effect, so that patient, can you see my? There. Okay, so that patient experienced a positive effect, but we didn't actually observe their outcome. And then these patients in pink down here experienced a negative effect. So if we didn't actually observe these because those patients dropped out, we would estimate a higher treatment effect than what the true treatment effect is. So if we had accounted for all of this data and we actually were able to observe the effects from these 8 patients, you can see that our estimate would have been lower. So we would have had an estimated treatment effect that was closer to the truth. So going back to experimental design, many of these threats to internal validity can be mitigated through experimental design. And we do this by trying to exert control over as many extraneous factors as possible. So what I mean by extraneous factors are any factors that can influence the, other than the intervention of interest, that can influence the outcome. So we can control for these extraneous factors in many different ways, either by controlling the exclusion criteria, or adjusting for some of those factors in our analysis. Randomization can also protect us from any unknown factors that could bias the outcome. And when we're trying to protect for internal validity, we also want to use as objective of an outcome measure as possible. And then again, adequately sizing our study to minimize the impact of sampling variation will also protect for internal validity. So this experimental design is what us statisticians spend a lot of time thinking about, but we often don't have the scientific expertise to make all the design decisions, which is why this is a collaborative process and can't be done only by the statistician or only by the investigator. We need to work together to control for all the possible sources of variation and to minimize errors. So we begin with the research hypothesis, and we have to narrow it down to a specific testable research question. From this, we can determine what is the intervention, what is the outcome, what measurements do we need to take, how are participants going to be assigned to these treatments, and then what are the sources of variation and how can we minimize these sources of variation that are not the conditions of interest. So I want to lay the groundwork for the big picture here, and that is that there is no perfect study. All studies depend on incomplete evidence that have flaws and limitations. So by incomplete evidence, I mean that we are limited to subsets of individuals drawn from a larger population. And these flaws and limitations can lead to incorrect conclusions. And it makes sense that the more flaws and limitations the study has, the less certainty we have in the evidence it produces, because it's more likely to produce inaccurate results. So if you start reading up on this topic, you'll often come across a pyramid structure like this, describing the hierarchy of scientific evidence. And it classifies study quality first in terms of the type of study design that was used. And to start, studies are classified as either observational or experimental studies. So the differentiating feature here is randomization. So this is how we control for unknown sources of variation. And experimental studies give us a higher degree of confidence in our conclusion, but they also come at a cost. And this cost is the added complexity of an experimental study. So they generally require higher numbers of patients, higher costs, longer durations, more planning, and also more ethical considerations. So the most rigorous form of scientific investigation is the experiment. And the goal is to determine a cause and effect relationship. So the cause is the action or the independent variable or the exposure or the intervention. And then the effect is the response or the dependent variable. So if we drill down further, we can see that we can actually classify designs into one of a few more specific categories. And these categories are defined by other features. So we'll still have randomization, and you can see here that the only individual study design that is experimental is the randomized controlled trial. So this is why it's referred to as the gold standard of scientific evidence from individual studies. The other studies below it lack randomization. This means that individuals self-select into the conditions of interest. So for example, some participants may be smokers and some participants may not be, and the defining features of these other types of designs are beyond the scope of this talk, but directly relevant to what we're discussing today. So I would encourage you to read up on this hierarchy of evidence, beginning with this 2016 paper that I have linked here. And then you can see at the top of this pyramid, we have meta-analysis, which is a unique study design that incorporates the findings of many other studies. So what is better than one randomized controlled trial? Really, the only answer is many high-quality randomized controlled trials. So there's different features of experimental designs that distinguish, or study designs that distinguish one from another. So the distinguishing feature between longitudinal and cross-sectional studies are whether or not there's some kind of time component. So is everything happening at once, or are we trying to look at how things change over time? And then forward versus backward directional refers to how we define the comparison groups. So in forward directional, we would identify the cause and then interpret its effect. And in backward, we would identify the effect or the outcome and then look backwards to look at its cause. And then if it's prospective or retrospective, so if it's prospective, the measurements are happening in real time. And then if it's retrospective, we're collecting things that had happened in the past. And then again, randomized versus not randomized. So there are multiple ways that we can randomize a study. Simple is where we randomize at the individual level. So each subject has an equal chance of being assigned to each group. Block randomization randomizes at the group level at regular intervals. Stratified randomizes at the subgroup level based on some participant characteristic. And then adaptive randomization is more complex. In adaptive randomization, we would allocate probability. The allocation probabilities would change over time. So this can allow us, for example, to assign participants to better controlling arms based on some interim analysis over the course of a study. So then we also have controlled versus uncontrolled. There are different types of controls we can use. Concurrent, which are controls that receive their intervention at the same time as the intervention group, and then historical, which are controls from a previous study that we can use as the comparator group. And then blinded versus unblinded or open label. So there's different types of blinding. We can have single blind where only the participant is blinded, double where the patient and the investigators are blinded, and then triple where the patient, investigator, and the data analyst are all blinded. And then we can have repeated measures or measurements taken on an individual at multiple time points in a study, or we can have independent measurements where one independent measurement is taken on each individual. And repeated measures allow us to account for within subject variation or between subject variation. So you can define each of these characteristics for a study, and this can help you determine what type of study on this pyramid that you're looking at. So it can also be a combination of multiple classifications. This isn't like a set list that every study will fall into. There could be a different combinations of different aspects of these studies in the final study design. So the gold standard, like I said, is the randomized controlled trial. So we're going to begin with that. We're going to talk about all the complexity associated with the randomized controlled trial and how that complexity helps us ensure internal validity. And then we'll work our way down from the pyramid. So I touched on this briefly a minute ago, but I wanted to go into more detail. So prospective or retrospective identifies when the cohort is identified relative to when the outcome measurement is obtained. So in a randomized controlled trial, this type of study is prospective because we enroll patients and then we take their measurement, as opposed to having measurements that have already been taken. And then forward versus backward directional, these refer to which groups we are comparing. So are we comparing the groups based on their exposure or based on their outcome? Forward or backward directional defines what are our comparator groups. So I wanted to show this visually. So in a randomized controlled trial, we would enroll patients. So this enrollment is represented by a circle, and then our outcome measurements are represented by a triangle. So in a randomized controlled trial, we would enroll patients, and then we would take their outcome measurements. In a prospective cohort study, we would do the same thing. We would enroll patients and then collect their outcome measurements. In a retrospective cohort study, we would enroll patients and then we would look backwards in time at outcomes that had occurred in the past. So we would rely on either the patient recall or any historical records that have been taken. And then same with case control. Cross-sectional is a little different since we don't really have a time component in a cross-sectional study. We just know that these things have already occurred. And then, so the directionality of the investigation. So this is either going to be forward or backwards. So in a randomized controlled trial, our comparison groups are based on the exposure, and then the measurements being compared are the outcome. Same with a prospective study, and then same with a retrospective cohort study. Case controlled study is backwards directional, and this means that our comparison groups are based on the outcome, and then our measurements being compared are based on the exposure. And then cross-sectional is non-directional, so you typically have measures of several different exposures and several different outcomes, and then you're looking for associations in that type of study. So the defining features of a randomized controlled trial are, one, they're prospective, so we enroll patients and then we collect their outcome measure. It's also forward directional, so the comparison groups are based on the exposure, and then the measurements being compared are the outcomes. And then the randomization is what ensures that the treatment groups are similar in all aspects, except for the exposure that they received. So if we observe differences in outcomes, we can be confident that those are a function of the exposure and not a function of any extraneous variables. So these characteristics all increase the confidence that we have in a randomized controlled trial. So let's look at a hypothetical randomized controlled trial where we have a treatment group and a control group. So if we have 200 patients in our study and we randomize 100 to the treatment and then 100 to the control, we often want to understand the chance of experiencing a positive outcome as a function of which treatment was received. So in this case, our outcome would be the proportion of patients who experience an outcome over versus the patients who received the treatment. So here the numerator is the number of subjects who experienced some outcome, either positive or negative, observed from the random data. And then the denominator, which is the number receiving treatment. So this is considered fixed by this design. And this is going to become important later when we talk about retrospective studies. And so our numerator will be observed from the random data. So in randomized controlled trials, if you look at the literature, you'll often see this patient flow chart. And this allows us to look at which patients were followed up completely in the study and which patients were lost to follow-up and any compliance issues with the study treatment. So this can help us identify some weaknesses. Even though randomized controlled trials are the gold standard, there are some weaknesses. One is that they're not always feasible or ethical to conduct randomized controlled trials. They're often very resource intensive. There's often compliance issues. So if you're submitting a study to the IRB, there's often a lot more scrutiny on randomized controlled trials. It takes a lot longer to get those through than any retrospective or observational studies. And loss to follow-up is always going to be an issue with randomized controlled trials. Individual studies are always at risk of inaccurately estimating exposure versus outcome relationships because of bias and sampling variability. Like we talked about before, bias can result in a systemic distortion of the relationship, and then sampling variability can mask the signal and the noise. So in addition, individual studies may not generalize across different populations and settings. So that's why we need to conduct multiple randomized controlled trials. So in this figure, we can see the results of 6 different studies, and each study was designed to detect whether corticosteroids given during the antenatal period are effective in accelerating fetal lung maturation in women at risk of preterm birth. So this figure displays the risk ratio and the 95% confidence interval for moderate to severe respiratory distress and syndrome comparing corticosteroids to the control. So we can see that some studies, so this line at 1 will indicate whether the treatment reduced the risk or increased the risk. So we can see that some of these trials demonstrated effectiveness of the corticosteroids by reducing the risk, while some did not. So the last three did not. So this also displays the confidence interval. So if the confidence interval crosses this line at 1, there's not a statistically significant effect. So individual studies cannot generalize across heterogeneous populations and settings. So that's why we need to conduct multiple randomized controlled trials and look at the results of all of those. So an individual randomized controlled trial is designed in such a way that sources of bias and noise are eliminated or minimized in order to get the most reliable and valid estimates possible. However, every study has its limitations. So either because of its size or because of just the way the study was conducted, these limitations can help explain different variations in the outcome. So that's why methods like systemic reviews and meta-analyses sit atop the hierarchical pyramid of evidence. So systemic reviews are literature reviews that are focused on synthesizing all high-quality research evidence relevant to the research question. And then meta-analyses are statistical syntheses of results from 2 or more primary studies that address the same hypothesis in the same way. So meta-analyses systematically examine the strengths and weaknesses of the accumulated evidence from randomized controlled trials. They can explore the heterogeneity between studies. They can identify potential biases, and they can provide an overall estimate of the benefit or harm of a treatment. So how can we determine the current state of evidence? So meta-analyses are conducted in a manner similar to that of a randomized controlled trial. However, rather than recruiting subjects into our trial, we'll conduct a search to include in our meta-analysis. So the Cochrane collaboration provides guidelines for conducting these systemic reviews or meta-analyses and includes how to identify, appraise, and synthesize research-based evidence. And then PRISMA is another organization that provides specific guidance on the conduct and reporting of a systematic review and a meta-analysis. So here is an example of one reporting requirement for both these organizations. So it's a flow chart depicting how studies were identified for inclusion in the meta-analysis and our systematic review. And you can see it's very similar to the patient flow chart that we looked at for the clinical trial. So step 1 in conducting a systematic review or a meta-analysis includes defining the research question and writing a detailed protocol for conducting a study. So in this protocol, we would include details like how the studies will be identified, how they'll be evaluated, and then what statistical methods we'll use to synthesize the results. So as in clinical trials, the best practices for reproducibility require pre-registration of the review and protocol. And this registration can be registered by clicking on this link, and this allows us to tell everyone that we know what we're going to do before we do it, and this allows us to be held accountable by our peers, and it also allows readers and consumers of our literature to go and see for a study, did they pre-register a protocol? And then if they did, are they reporting the findings according to the way they said they were going to, or did they deviate from that plan? So once the protocol has been developed, then we would conduct a search of the literature according to the directions defined in that protocol. So in general, a PICO approach will identify many of the relevant studies. So this is the patient population of interest, the intervention of interest, the comparator, the control group, and then the specific outcome of interest. So we would often conduct a search by putting these terms into Google Scholar, PubMed, or some other search engine to help us identify published studies. So once the pool of relevant studies has been identified, each should be appraised for quality. Quality is another term for the risk of bias, in that studies with a low risk will have a higher quality of evidence. So in this figure on the left here, we have displayed several specific sources of bias, and then the authors of this meta-analysis have reviewed and classified each of these studies as having either low, unclear, or high risk for each of these sources of bias. And then we have a summary of the percentage of all studies with each level of risk here. So then next, the author of the systematic review or meta-analysis will write a narrative synthesis of the findings, including details on the quality of each of the studies and their interpretation of the current state of evidence. So in a meta-analysis, this is taken one step further by actually using a statistical method to pool the results of a study and to obtain an overall estimate of the effect. So this is done using what's basically a regression model that takes each treatment effect from each of these subjects and then computes a weighted average, or where the average weights are determined by the quality of evidence using that evaluation of the risk of bias that we saw in the previous slide. So here we're going back to the figure that I showed earlier. So the pooled estimate of the risk ratio displayed at the bottom of this figure is represented by a black diamond. And the pooled risk ratio here is 0.59, and then it also gives you a 95% confidence interval. So the results of this analysis indicate a benefit of the corticosteroids, specifically a 41% reduction in the risk of moderate to severe respiratory distress syndrome. So a meta-analysis just means analysis of the analyses, and it answers several questions. So it answers, what is the direction of the treatment effect, or does the treatment effect have a negative or positive effect on the outcome? What is the size of this effect or the magnitude? The consistency of the effect across studies, which we call the heterogeneity. So this is in that previous figure where we saw that there's a lot of bouncing around of the risk ratios. So this heterogeneity is how those inconsistencies that we saw in the results of those studies. And then the strength of evidence, or the quality of the assessment and the risk of bias. So the higher the consistency, the higher the strength of evidence, and then the lower the consistency, the lower the strength of evidence. So visually, meta-analyses give us a lot of tools for looking at the state of evidence, the first being the forest plot. So I'm going to go more into forest plots. Forest plots are typically like the ones shown here. They plot the individual estimated treatment effects and confidence intervals on a single figure. So here the estimated treatment effect is the risk ratio. So it's displayed for each study that is represented in these blue boxes. And notice you can easily see both the direction and the size of the effect. So the further away from one this risk ratio is, the stronger the association is between treatment type and outcome. In addition to the point estimate of the risk ratio, we're also given the interval estimates. So since this effect size measures the risk ratio of 1, a risk ratio less than 1 indicates a reduced risk of the outcome associated with the treatment. A study whose confidence interval falls completely below 1 provides evidence of a benefit of corticosteroids in preventing hemorrhage. So it's also important to note the size of the marker for each estimate. So the bigger the box, the more that individual estimate is weighted in the final overall risk ratio estimate. So for example, this one, we have a risk ratio of 0.57. Because this was also one of the larger studies, it provides more weight towards the final estimate. So this is weighted at 17.2%. Smaller studies like this one contribute a lot less to the final estimate. So this has a weight of 2.5%. Like I said before, the final result is going to be a weighted average of the study findings, and it's represented by this diamond on the bottom of the plot. And we can see that this estimate is a lot closer to the one that had the higher weight, and that's because this higher weighted study contributed a lot more to the final estimate than the smaller studies. Inevitably, studies brought together in a systematic review and meta-analysis will be very different. So any kind of variability among the studies may be termed heterogeneity, but it can be helpful to distinguish between the different types of heterogeneity. Variability in the participants, interventions, and outcomes can be described as clinical heterogeneity. And then methodological diversity is sometimes called methodological heterogeneity, which describes variability in the study design and in the aspects of the study design, like sample size or how the researchers protected against bias. So variability in the intervention effects being evaluated in the different studies, as visualized in this forest plot, is known as statistical heterogeneity. And this is a consequence of clinical or methodological diversity, or both, among the studies. Statistical heterogeneity is identified when the observed intervention effects being more different from each other than one could expect due to some random error or chance alone. So it's important to consider to what extent the results of the studies are consistent. Like I said before, the consistency can be viewed in these forest plots by looking at how much the dots and the lines bounce around. So if the confidence intervals for the results of individual studies have poor overlap, this generally indicates the presence of statistical heterogeneity. So more formally, a statistical test for this heterogeneity is available. So we use what's called the I-squared statistic, and this describes the percentage of the variability in the effect estimates that is due to clinical or methodological heterogeneity, as opposed to the sampling variability. So for example, here you can see that the I-squared statistic is 32. So this means that 32% of the variation observed in these treatment effects is likely attributed to true heterogeneity because of population differences in the interventions, or differences in the outcome, as opposed to the sampling variability. We want this I-squared statistic to be as low as possible, because we want the heterogeneity related to, or the sampling variability to be more important than the methodological differences, or the variability attributed to those methodological differences. So this is a rough guide to interpret the I-squared statistic. So if it's 0 to 40%, these methodological differences may not be important. 30 to 60 represent moderate heterogeneity. And then as it gets higher, we can see more, these represent substantial or considerable heterogeneity. Meta-analyses are not without limitations. So one limitation that we talked about a little bit earlier is publication bias. So searches of databases like PubMed can yield long lists of studies, but these databases only include studies that have been published. So these searches are not necessarily going to be representative sample of the whole population of studies that were conducted. And that's because a lot of those, or some of those studies that may not have shown a positive result may not have been published, either because the researcher decided not to publish them, or the journals didn't accept them for publication. When conducting a meta-analysis, there should be considerable effort made to identify unpublished studies. These unpublished studies can be identified in registries like clinicaltrials.gov that have all of the studies that were conducted, rather than just the ones that were published. The National Institute of Health also maintains a registry of all of the studies it supports, so this can help researchers identify any studies that haven't been published. One way that you can look at the risk of publication bias in a meta-analysis is with what's called a funnel plot. Funnel plots are tools that are often reported. You may have to look in the supplementary materials of a study to find these funnel plots. But the way that you would create a funnel plot is by plotting the x-axis, or on the x-axis, some estimate of the treatment effect or the outcome measurement. So in this case, it's the odds ratio. That's on the x-axis, and then on the y-axis, we have some measure of the sampling variability. So here it's the standard error of the log odds ratio. So larger studies will have a smaller standard error of the log odds ratio, and this you can see that this axis is actually reversed. So the larger studies will be on the top of the plot, while the smaller studies will be on the bottom. So this is because the larger studies will have less sampling variability. So as we move up the y-axis, we should see the sampling variability decrease. And the funnel plot should look like a funnel. So if there are no major concerns with regard to publication bias, we would expect it to look like the plot on the top. Whereas if there is a risk of publication bias, it would look more like the bottom plot. So since publication bias usually results when studies with non-significant findings are not published, and since smaller studies have a larger chance of non-significant findings, we may see an asymmetry in the funnel plot when these studies are not included. So these studies here in the top plot are indicated with the open circles. So when we remove those, we can see that the funnel plot looks more like the lower figure, which is what this would look like in the presence of publication bias. So here are studies with higher sampling error, but with an unfavorable result. So that's an odds ratio greater than 1. Did not get published either because the investigator chose not to publish it or because journals wouldn't accept it. And this results in an over-optimistic estimate of the odds ratio. So in the bottom plot, the odds ratio is around 0.5, the overall one, indicating that there's a reduction in risk of about 50%. While in the top plot, when we're accounting for all studies, we can see a reduction of risk of about 40%, based on an odds ratio of 0.6. So by definition, the outcome of a meta-analysis depends on which studies are included. So even in the ideal case where all relevant studies are available, that is where there's no publication bias, faulty search can miss some of them. So in searching databases, when you're conducting a meta-analysis, great care should be taken to ensure that the set of keywords that you're using is as complete as possible. So this step is so critical that most recent meta-analyses include a list of the keywords that they use. So the type of search engine is also important, and that's because this affects the type and the number of studies that are found. Small differences can actually produce very large, small differences in searching strategies can actually produce large differences in the sets of studies that are found. So another potential limitation of meta-analyses is what's called selection bias, where small differences in the inclusion or exclusion criteria can produce large differences in the sets of studies included in the analysis, and this can impact the overall conclusion. So moving on to observational designs, we're going to go through each of the types of observational studies and what the characteristics of those studies are. So one step down from a randomized controlled trial is what's called a cohort study. These are optional observational studies where investigators select study subjects based on their existing exposure status. And this involves a forward direction of inquiry. So these are designed to assess the association between the exposure and outcome. There's two different types. There's the prospective study, which involves real-time measurement, and then retrospective, in which we rely on historical measurements. So the simplest cohort study design is a prospective cohort study. So notice the directionality here. The exposure is observed prior to when the health outcome is observed. So that's what makes this a forward directional study. So in addition, study subjects are disease-free at present, and then the observation of the outcome, or whether or not they had the disease or didn't, is prospective. So the difference between this and a randomized controlled trial is selection bias, and that's because we're not randomizing patients to a treatment. So we can't guarantee that the groups of patients are going to be similar in all respects except for the exposure. So there may be differences in how the patient was treated that may be a result of, for example, like doctors may include an intervention for only low-risk patients rather than high-risk patients, and then that would inflate the overall effect in the study of that treatment because you're treating healthier patients. And so it may look like there was an effect of the treatment when actually the observed treatment effect may be due to the types of patients that were actually treated. So retrospective cohort studies, here exposure is still observed prior to when the health outcome is observed. So this is also a forward directional study. However, all observations occurred in the past from sources like medical records and charts. So like chart review studies are going to be retrospective cohort studies. So this may lead to some additional bias based on either patient recall or mismeasurements in the past. This is kind of what I was talking about earlier, which can arise in observational studies where we have a nuisance factor, which may confound the observed association between, for example, in this case, treatment and mortality. So here the nuisance factor is the presence of arrhythmia in a patient. So notice that there's an imbalance of how this confounder between the two groups. So if we look at only the patients who did not have the arrhythmia, we can see that the mortality is 10% for both groups, meaning that there's no treatment effect. But if we looked at the mortality rate for those with the arrhythmia, the mortality rate is also the same. However, in the treatment group, we have more patients without the arrhythmia than patients with the arrhythmia. And so when we pool these results, we can see that the estimated overall mortality is less than the control group. But this isn't due to any effect of the treatment. It's due to the imbalance of those with an arrhythmia versus not in the treatment group. So randomization provides protection against this confounding. So notice how if the investigator takes the clinical decision making out of the assignment and instead uses a random process, we end up with more balance in the confounder across the two groups. So now the only difference between the two groups is the actual treatment of interest. We also no longer see a difference in mortality, so we have an unbiased estimate of the treatment effect. Some strengths and weaknesses of observational cohort studies. Strengths are they're very efficient for rare exposures because the patients are identified based on their exposure. We can go directly to those patients who have experienced the exposure rather than if we take a random sample, we may not actually get the exposure, or we may not get any patients with the exposure. So this allows us to properly assess rare exposures. They're efficient. They're good for situations where the time between exposure and the outcome is long. And then one other strength which I'll get to, is we can estimate the risk of the disease. Weaknesses are selection bias. If it's prospective, we may have some lost follow-up, like with randomized controlled trials. They're also more resource intensive. With retrospective studies, those are also subject to information bias or misclassification bias, because we're looking at records from the past. Like I said in the previous slide, we're able to estimate risk of a disease using observational cohort studies. So the definition of risk is the probability of an outcome occurring given the treatment. So here, in this study design, the denominator is fixed from the design, so while the numerator is observed. So this would be an example if we're looking at the outcome variable of death. The risk would be the probability of death, given that. Yes, do you have a question? Yeah. Information bias is like when there's a bias in how the measurements were taken. Misclassification just refers to whether there was a difference in the classification. So they're very similar. Misclassification is actually a type of information bias. It just refers to classification. Yep. Okay, so here we can, because the number of patients receiving the treatment is fixed from the design, we can estimate this risk. So this is different from the odds ratio, which is the risk. Well, the risk is the probability of an event occurring given the total number at risk of that event. The odds is the likelihood of an event, or the ratio of proportions. When we do report risk, when do we report risks, and when do we report odds ratios? So that all has to do with the study design. So in order to estimate the risk of an event, the denominator, or the total number at risk, must be known from the design. And the reason for this is because, going back to the previous slide, so we know that the number of receiving the treatment, or the number at risk, is fixed from the design, and rather than the number of deaths being fixed from the design. This allows us to be able to estimate risk in a valid way. So as an example, if you think about like in a case control study, we would sample from the population 50-50, or as much as we can. Like 50% of patients would have the disease, and 50% of the patients won't. So if we use this sample to estimate the risk, we would have a risk of 50%, because that's how the study was designed, not because that's the actual proportion in the population. And then, so the interpretation of the risk ratio and the odds ratio is similar. The risk ratio of 1, or an odds ratio of 1, indicates that the treatments are identical. Less than 1, decreased risk or decreased odds, and greater than 1, we have increased risk or increased odds. So in this example, if we have 200 total patients, And out of the treatment group, 30 out of 100 experienced death. So that would have a risk of 30% for the treatment group. And then out of the control group, we have 20 experiencing death, so the risk would be 20%. So then the risk ratio would be 1.5. So the interpretation of this would be that the treatment is associated with a 50% relative increase in the risk of death. So odds are sometimes expressed as fractions. So for example, the odds of this would be 3 to 7, so 30 over 70. And then for the treatment group, and then the odds of death for the control group would be 2 to 8, or 20 over 80. So a 3 to 7 odds of death are associated with the treatment, which means that 10 treated patients, that if we treated 10 patients, we would expect 3 to die and 7 to survive. So that would have an odds ratio of 1.71, meaning that the treatment is associated with a 71% relative increase in the odds of death. Some strengths and weaknesses of observational cohort studies. Some strengths are that we can estimate the risk of the disease. It's efficient for rare exposures, and then if retrospective, it's efficient. It's good for situations where the time between exposure and outcome is long. And then some weaknesses, selection bias, and then loss to follow-up, resource intensive, and then retrospective information and misclassification bias. So we can see this selection bias in this patient flow chart, and we can see that there's an imbalance in the treatment assignments. Hey, Erica, it's saying that the system is going to turn off in a second. Oh. I think that's like a problem with this room, is it's just turns off. Oh, okay, it's back. It wasn't beeping, but it was telling me that like the system was about to turn off and I needed to click a button to keep it, but the button wasn't working. Yeah. Okay, I think we're good now. Yeah, maybe I might need to reshare my screen. Am I still sharing? Okay, all right. Okay, all right. For those online, sorry, we had some technical difficulties, but I think we're back. Okay, so next I'm going to talk about case control studies. So this is also an observational studies, except in this case, the investigators would select subjects based on their existing outcome status rather than their exposure status. So this means that we have a backwards direction of inquiry. And then this is also designed to assess the association between exposure and outcome. It's also retrospective in that it relies on historical measurements. So exposure is still observed prior to when the health outcome is observed. The health outcome is observed prior to when the exposure is observed, making this a backwards directional study. But in this case, it's still retrospective, just like the retrospective cohort study. And so we have our measurements taken in the past. So these would often come from medical records and charts, which also leads to bias. So some strengths of case control studies are that we can establish a temporal relationship between exposure and outcome. This is efficient for rare diseases. So that's because when we select the patients in the population, we can find those patients who have a rare disease and recruit them into our study, rather than finding the patients who have been exposed to a disease. So this is also good for studying several exposures simultaneously. And from case control studies, we can compute the outcome or the odds of a disease or exposure. In this case, risk would be inappropriate because, again, if we have a 50% of patients with the disease and 50 without, the risk would be 50%, which is not a representation of the whole population because we're selecting patients based on that outcome. So I'm going to show an example of a case control study. So in this study, we're looking at patients with cancer versus patients versus healthy controls. And then we're looking at whether they have a family history of cancer or not. So again, this, by the design of the study, this is known. So we know that we're going to select patients, a certain number of patients with cancer, and then a number of healthy controls. So we have about a third of the patients here have cancer. So here we have the risk is the number with disease versus the exposed. But again, we cannot, or the risk is not appropriate for this type of study because this number that's exposed is not fixed by the design. It's the number with the disease that's fixed. So here we would have to estimate the odds ratio as our outcome variable. So the odds are out of those with a history of cancer. We have the odds of cancer given that they have a history, which is 0.96. And then the odds of cancer, given that they have no history, is 0.43. So a 26 to 27 odds of cancer is associated with a family history, meaning that in 53 patients with a family history of cancer, we would expect 26 to develop and 27 not to. So if we calculate the odds ratio, we get an odds ratio of 2.23. And this means that a family history is associated with a 123% relative increase in the odds of developing cancer. So some strengths of case control studies. Again, we can establish a temporal relationship between the outcome and the exposure. It's efficient for rare diseases, again, because we can go directly to those patients who have the disease and recruit them into our study. They're good for studying several exposures simultaneously, and they allow us to compute the odds of the disease or the exposure. The weaknesses are we can't estimate the risk, which is often easier to interpret than the odds. So that's a weakness of this study. It's inefficient for rare exposures, and then it's dependent on the amount and quality of historical records or subject recollection. And then cross-sectional studies. These are descriptive studies where investigators select study subjects based on both their existing exposure and their outcome status. So this is non-directional because exposures and outcomes are both measured simultaneously. And then they're designed to assess the association between the exposure and the outcome. And then again, this is retrospective because it relies on historical measurements. So here we would have a population that we're selecting, and then we would measure both the exposure and the outcome at the same time. And then we would have groups based on those exposures and those outcomes. And then again, this is also subject to a selection bias because we don't have any assurance that the groups of patients are similar in all respects with the exception of exposure and disease. So some strengths are that they're relatively quick and inexpensive. They allow us to study several exposures and diseases simultaneously. And then they can estimate exposure burden and disease burden. Weaknesses are we can't establish a temporal relationship between exposure and outcome because we're taking those measurements at the same time. And then we can't identify incident cases, and we can oftentimes miss acute conditions. Ecological studies are another type of, they're similar to cross-sectional studies, except here the measurements are taken on geographically or temporally defined groups rather than individuals. So the exposures and outcomes are come from existing data sets, but these data sets will contain aggregate measures, so measures across a whole group of patients rather than individual patients. So this allows us to examine associations between average exposure levels and overall outcome rates at the group level, not at the individual level. So as an example, we may have an objective to see if there's more firearm laws in states associated with fewer firearm fatalities. So we can use the legislative strength score across 5 categories, and then we can look at the firearm-related fatalities. So this type of study would often result in a plot like this, where we have where instead of having individuals plotted, we have the states. So this has the legislative strength score on the x-axis and the risk of firearm deaths on the y-axis. So population studies or population level studies like this one can help us define important public health problems. Some individual level risk factors for disease don't vary enough within populations to identify or study effects, and that's one of the strengths of ecological studies is that they allow us to look at these risk factors over a whole population. So some strengths are they're relatively quick and inexpensive. We can look at several exposures and or diseases simultaneously, similar to a cross-sectional study. We can estimate exposure, the exposure burden and the disease burden, both. And then these are often used to generate hypotheses that are then tested in other more individual level studies. The weaknesses are the ecological fallacy, and this occurs when you make conclusions about individuals based only on the analyses of the group level. So oftentimes you can't extrapolate what's occurring at the group level or the state or county level, and extrapolate those to the individuals. So to summarize what we talked about today, not all evidence is of the same quality. So you can use this pyramid to understand how well or how much confidence you can have in the results of your study. Study design attempts to account for as many of these sources of variation as possible. But the gold standard for individual studies is the randomized controlled trial. And that's because randomization can mitigate both known and unknown sources of variation. So in parts 2 and 3, we're going to look at statistical methods that allow us to account for variation. So today we looked at how the study design can mitigate or account for this variation and help with internal validity. But even perfect studies can have a small chance of producing inaccurate evidence. So there are two sources of variation in the outcome measure, both bias and sampling variability. So bias refers to any systematic error, systematic difference from what the true estimate is, or the true parameter value in the population is. And then sampling variability comes from taking a sample from the population rather than looking at the whole population. So next time we're going to go into some statistical methods like the t-test, the chi-square test, to allow us to account for these different levels of variation and also to evaluate the results of our study. So that's everything for today. If you have any questions, my email is right here, or you can come up and ask after we're done. And then this feedback form, if you could fill this out, that would be great. There's one feedback form for all 3 lectures. So if this is the only one or you're attending, you can go ahead and fill this out. But if you plan on attending the next 2, you can fill this out once the 3 lectures are done. All right. Thank you, everyone. Yeah, you have a question?
How do you define those kind of studies that
Can you repeat what type of study you're talking about?
Very common observational study that compare 2 groups. Like one group with a specific disease, one group without that disease. And then compare 2 across different measurements. So how do you define this type of study?
So
it's like comparative observational study.
Yeah, so it would depend on how you're. Oh yeah, so he asked about what type of observational study is a comparator where you have 2 groups that you're comparing, is that correct? So the type of study would be dependent on how you're selecting patients based on those groups. So if you, going back to the case control study, if you're selecting patients based on whether they have the disease or not, that would be a case control study. And then if you're selecting patients based on whether they have an exposure or not, that would be a retrospective cohort study. So they're similar, but it all depends on what how you're selecting the patient population. Yeah. All right. Did anyone else have any other questions? Okay. All right. Well, thank you so much. I hope to see you guys next week and the week after. Thank you.